Hello, my name is Dr. Brian Reid, and I'm a naturopathic doctor, and this is a video about low-dose immunotherapy, part 2. So in part 1, which I posted a few days ago, I just talked about kind of the basic background of low-dose immunotherapy. It's developed by this medical doctor named Ty Vincent. It's an offshoot of low-dose allergen therapy, and it's pardon me, it's a therapy that I've been using in my practice for, I think, oh my goodness, maybe 7 years now. I can't remember, something like that, 5 to 7 years anyways. And it's a therapy that in well-selected cases can be incredibly helpful and incredibly effective. The key words there being well-selected. So as I mentioned in video number 1, the basic premise behind how we believe that LDI probably works is by addressing an underlying sensitivity, kind of could think about it as sort of like an allergy, if you will, to the underlying microbe, or sometimes other substance that a patient's reacting to. We'll talk about microbes, but it could be hormones or possibly certain chemicals or different things like that. It doesn't have to just be a microbe. And so if a patient, kind of a classic well-selected patient would be a patient who has either clinical, strong clinical evidence suggesting that there's underlying borreliosis or Bartonellosis or Epstein-Barr virus issues or whatnot, and then so whether it's clinically suspected or we have the lab testing indicating that, supporting the clinical assessment that yes, there does seem to be an underlying infection, and then we treat those patients with herbs or IVs, or maybe they've used pharmaceutical agents or whatever it happens to be, but we've kind of been killing off the microbes, and the patient's hopefully feeling better, and it could be they're 20% better, they might be 85% better, but the patient has improved with the killing approach, but then they hit a plateau. And if they plateau, oftentimes I'd look at biofilm disruptors and things like that as the next step, but let's just say for argument's sake that the patient has, been on comprehensive antimicrobial treatment, we've looked at biofilms, we're working on supporting their mitochondrial function and their overall physiology, and their gut's healthy and their diet's on track, and we're kind of treating everything, but the patient has hit a plateau. And also, they find that if they try to back off their antimicrobials, then they will start to feel worse again. So that would be a fairly textbook case that might respond very well to LDI. The idea, which is low-dose immunotherapy, so the idea there being that we've been killing off the microbes, we've been knocking the numbers down notably, but if there's still little dregs of these microbes left, and in the example of a virus, to my understanding, viruses are something that to my understanding, we can't fully ever totally get rid of. We can really knock down the viral load, but there's going to be remnants of those viruses left in our system. There's also some research evidence, and also certainly wide clinical evidence that suggests that we may have persistent low levels of Lyme and like Borrelia and co-infections that might persist in our bodies even after a person's 100% well. And so the idea being, in video 1, I mentioned the dust analogy, where if you're allergic or sensitive to a microbe, even if there's tiny little bits left, then you might still have symptoms. So the dust analogy example, if you have this really dusty house, the patient's allergic to dust, they're going to be super reactive. They're going to be having tons of histamine reactions left, right, and center. You can really knock down the dust level, but there's always going to be a little bit of dust in any house, and so they might still be a little bit symptomatic. And then if they aren't quite as fastidious with dusting or vacuuming or whatever it is, and the dust level increases even just a little bit more, they're going to probably become exponentially more reactive. So in a similar model, if there's still a little bit of Borrelia left in a person's body, and they're 80% well, but they're just not 100% well because there's still that little bit of Borrelia that they're reacting to, and then they back off their antimicrobials, so the levels of Borrelia start to increase just a little bit, then they can start to feel disproportionately worse. So those patients who say, I do better on antimicrobials, but if I back off of them, even within sometimes hours or days, or the most weeks within stopping them, they start to flare up again, and it's as clinicians, we're pretty sure that it's not related to biofilms, which is a DDX for that type of thing in my experience, then low-dose immunotherapy could be indicated because it suggests, well, maybe they've got that sensitivity issue and the Borrelia is increasing just a little bit or the Bartonella is increasing just a little bit, and it's enough to trigger the immune system to have this inflammatory reaction and then they feel worse. So that would be a good... That's kind of the type of pattern that I would consider to be a classic screening question or thought in my head of like, if I'm seeing that pattern, there's a significant chance that there might be a sensitivity to the microbe and LDI might be really effective. So I will post again about this, maybe just a couple of case examples, because I know it's a really different concept. Thinking about microbial hypersensitivity. I mean, people do talk about mold allergy and mold sensitivity, but like a Lyme bacteria sensitivity, like it's such a crazy foreign concept. And when I first heard it, I think it was about 7 years ago from Ty Vincent, it was just my brain exploded. I was like, oh my gosh, I've never thought about that possibility before, and that really just it blew my mind. And then it has been very helpful for, well, at the time it was very helpful for a number of cases that I had otherwise been stuck on. And then moving ahead, certainly not every case needs LDI in my experience, but in well-selected cases, it can really be a game-changing therapy. So anyways, I'll talk about some cases coming up soon.